Good afternoon and welcome to Wednesday Wellness, a free live educational series brought to you by Trinity Health. We're thrilled to have you with us as we dive into learning about evidence-based steps to prevent colorectal cancer. Before we get started, here are a few housekeeping notes. Your cameras and microphones have been turned off to ensure a smooth experience. If you have questions during the presentation, please use the Q&A chat feature located at the bottom of your screen, and our presenter will address these questions at the end of the session. Lastly, today's webinar is being recorded and a link to the video will be sent to your email in the coming days. Without further ado, I am pleased to introduce medical oncologist Dr. Daniel Taylor.
So hi, everyone. Thank you for the opportunity to talk about this topic that's so near and dear to me. This is certainly not an all-inclusive, every possible thing you can do to reduce your risk of developing colon cancer, but I thought I would just kind of go through some of the studies that have been done in the medical field to try and figure out what are risk factors for colon cancer and what steps we can take just with diet, activity, and supplements that we can use to try and reduce our risk, and then some of the medical interventions that have been so valuable in helping reduce our risk, and then kind of talk about some emerging data, and then hopefully we'll have time for some questions at the end. I don't have any relevant financial disclosures. I'm not talking about any sort of therapeutic medications that a pharmaceutical company asked me to talk about or anything like that. Most of these are low cost, easy to implement interventions that you can do to reduce your risk. Here's the overview. Besides just the things that we can do to try and reduce our chance at getting colon and rectal cancer, I'm going to kind of talk about the cancer, why it's so important, how common it is, and sort of the worrisome findings we're seeing as a medical community about how there's increasing numbers of young people who are not being screened, who don't meet qualifications for screening, but are still getting this cancer that used to be seen primarily in folks who are older than 50. So with that, we'll just kind of launch into it. So it's the third most commonly diagnosed cancer in the world. It's the second deadliest in the US. There's 154,000 new cases of large bowel, which is the colon. I'm not sure if you can see my mouse, but hopefully you can all see this, the dark pink mass there, or the dark pink intestines there is the large intestine. That's what we're talking about. And that very last part of it kind of exiting the body is the rectum, which is included in my colorectal cancer statistics. So 53,000 deaths annually, and then a lifetime risk of just your average person of about 4%, which certainly sounds high. It's more common in males than in females, more common in Black Americans than white Americans. And it can be related to inherited genetic conditions, which we'll discuss a little bit, but it oftentimes and more frequently is developed spontaneously through just mutations that happen as we live long enough. Mortality in the US has been declining since the mid-1980s, which is a great thing. This is largely due to how effective we've been at implementing colonoscopy screening programs and other colorectal cancer screening things like the FOBT test, the FIT test, the Cologuard, things like that. Unfortunately, mortality among patients who are under 50 years old has increased by 1% every year from 2004 to 2018. And since then, it's even gone a little bit higher, although there's less data on it. And this is particularly noticeable in white and Hispanic populations. So you can see this graph. You don't need a statistics degree to see that line kind of going way up. You can kind of see it start to really go up towards the end of the 30s, beginning of 40s, and then it just takes off as you get older. That's the incidence of colorectal cancer by age. So you can kind of see that incline is what we're looking at, and that's slowly moving to the left, which is worrisome for us. So we'll talk a little bit about the recommendations for when to start colonoscopy and how that age has recently, not that recently, but relatively recently been changed from 50 to 45, and how there may be some emerging data to suggest we should even push it lower than that. The fact that there's so many young people getting colorectal cancer has alarmed epidemiologists and allowed us to try and do some research into figuring out what's causing this. So there's a lot of ongoing trials and studies to kind of figure out what is it about, particularly the United States, where we're seeing younger and younger people getting colorectal cancer. And yes, a third of them are hereditary syndromes, which we expect those folks to have a higher risk of developing colon and rectal cancer early. But we also are seeing it in other populations who don't have inherited conditions. And there's been a lot of suggested reasons for this. Certainly obesity, metabolic syndrome, fatty liver disease, sedentary behavior, increase in red meat intake, lack of fiber, high blood pressure, high cholesterol. All of those things are associated with risk of colorectal cancer. Having a family history of colorectal cancer without a genetic condition can certainly also be a risk factor for cancer. We may just not know how to test for some of these conditions yet. And then alcohol consumption is being found to be more and more associated with all solid tumors, but particularly cancers of the intestinal tract. And then vitamin D deficiency is something that's been studied for a long time. And there's a lot of evidence to suggest that if you're chronically vitamin D deficient, which in Michigan is certainly worrisome, then you can be at increased risk for solid tumors, all solid cancers, but colorectal cancer in particular. So first off, I'm going to talk about primary prevention of colon cancer. Primary prevention means things that we can do to reduce the risk of ever developing colon cancer. And then later, I'm going to talk about secondary prevention. The definition of that is things that we can do to catch cancer early and screen for it so that if we do have it, we're able to take care of it fast. I'm going to talk about broadly 4 topics: diet, alcohol, supplements, and physical activity. And then in diet, I'm going to kind of dive into a few things. And some of this data, you have to remember that with all clinical trials, when we're investigating this diet as a reason for something, it's very challenging to do these in a controlled environment. So the data is not as robust as we'd like it to be, which is why we want more and more experiments done to see if we can reduce the risk of colorectal cancer further. But we do have enough data to give us some ideas about what we should do to reduce our chance at getting colon cancer. So the first thing I'm going to talk about, and as someone who's born and raised in rural Texas who grew up on red meat, this is definitely alarming for me. And I think a lot of people who enjoy red meat are going to find this alarming. So it's red meat, in particularly processed red meats like sausages and jerkies and things like that, have been found in many studies to be strongly correlated with colorectal cancer. So I'm going to just talk about a couple clinical trials here. Red meat and colorectal cancer found that the high intake group, which is more than 160 grams a day, had a risk of 1.35 times as much as the lowest intake, which is less than 20 grams a day. I know we don't typically talk about meat in grams, but that's kind of how all these clinical trials are done in order to be objective. Consumption of red meat and processed meat in cancer incidence, a systematic review and meta-analysis, which is kind of a collection of a lot of clinical trials where they look at all of the various trials and what they came up with for risk factors, found that processed meat consumption was significantly associated with a 6% greater breast cancer risk, a 21% greater colon cancer risk, and a 22% greater rectal cancer risk, as well as a 12% greater lung risk. So this isn't just colorectal cancer, but certainly colon and rectum are the most impacted by increase in red meats. In general, eating less red meat is beneficial. Eating less or no processed red meats seems to be very beneficial. The American Institute of Cancer Research recommends no more than 18 ounces of red meat weekly. So if you can kind of do the math and see how many ounces of red meat you're typically eating in one portion, you can try and reduce your total number of weekly portions to about 18 ounces to try and reduce your chance of getting colorectal cancer from red meat. Another thing I'm going to talk about is fiber. I think this was eye-opening for a lot of folks who have read about fiber and know that it's important to get fiber. And roughly we know what kind of foods have high fiber in general, but the amount of fiber we need to kind of meet the recommended requirement is much higher, I think, than most people are eating. And that's kind of corroborated by some of these clinical trials where on a review of American men, women, and children, 95% of Americans are not getting enough dietary fiber. The National Academy of Medicine gives some fiber recommendations. You can see them right there, but I'm just going to kind of talk about the 25 to 40 grams of fiber recommended for adults. And then I'm going to show a graph of some of the amounts of fiber here in a little bit in foods. So you can kind of see how many portions of foods that we don't normally eat we would need to kind of meet the requirement for these fiber intake recommendations. Another topic is sugary drinks. Certainly, we've long suspected that increased risk of sugar not only puts at increased risk for metabolic syndrome and obesity, but sugar by itself is a risk factor outside of obesity just for getting colorectal cancer. So for folks who had less than one serving a week of sugar-sweetened beverages, compared to women who consumed at least 2 servings a day, had more than double the risk of early onset colorectal cancer. And then for every increase in serving per day, there was an increase of 16% risk of cancer. So for folks who are having 2 or 3 or 4 sodas or sugary drinks a day, you're increasing your risk of developing cancer by that much. And there was another clinical trial that reviewed for folks who switched their drinking patterns and stopped drinking sugary sweetened beverages and switched to artificial sweeteners or coffee or reduced fat milk. They had a 17 to 36% decreased risk of developing cancer. So something to consider if you're someone who really enjoys soda like myself, cutting back and switching it out for something that has less sugar is certainly beneficial and more than just this cancer reduction, but also in general for metabolic syndrome and obesity as well. This is that graph. This is from the Mayo Clinic. This is a graph of kind of the average fiber in grams. So you remember that I was talking about adults needing about 25 to 40 grams of fiber a day. And so you can kind of imagine that if 23 almonds, which is like a pretty hefty amount of almonds, is only 3.5 total grams, you have to be eating a lot of almonds to get to that fiber intake recommendation of 40 grams for a man. Same thing with bran flake cereal. It's kind of marketed as having a high fiber, but it's really only 5.5 grams. And you need a lot of that to kind of meet the requirements. So things like split peas, black beans, lentils, these are the things that have the most bang for your buck. So incorporating more of those lentils and black beans into your diet can increase your fiber and also decrease how much sort of processed sugars and carbohydrates you're taking. So that can help on multiple fronts. And for the record, I think that you can cook lentils and have them be delicious as well. So it doesn't have to be not tasty. Similarly, for fruits, we think of fruits as being really high in fiber, but it's a modest amount. You have to eat a lot of that and replace a lot of your carbohydrates with these if you're going to keep your calorie level the same and try to increase your fiber. So you can find these graphs all over the internet, but the Mayo Clinic has I think a really helpful one with kind of traditional American servings. Another topic is vitamin D deficiency. I think a lot of people are in general aware of the risk of vitamin D deficiency in the Midwest, in particular Michigan. There was a study done at an OB clinic at a smaller hospital in Michigan that suggested that 92.5% of women have low vitamin D on blood testing when they were checked in the winter. And that tracks with my experience of testing people in Michigan, that vitamin D is just low in almost everybody, unless you're very intentional about taking it. There's multiple types of vitamin D supplementation. Vitamin D3 seems to be more effective at increasing our vitamin D levels and also decreasing our risk of cancer. That said, there's also been some clinical trials that I'm not going to address here that suggest that natural sources of vitamin D, like sunlight and sunlight and dairy products, can be more beneficial for replacing vitamin D than vitamin D supplementation, but vitamin D supplementation does help. Alcohol consumption. I've been told that Grand Rapids is beer city, and ever since moving here, that seems to be the case, that there's a lot of breweries. And so I know that this is a cultural popular thing to do. And I'm going to talk a little bit about the historic recommendation for how much alcohol people should have. We're finding is probably still too much alcohol as far as increasing folks' risk of developing cancer. And so when they did one large clinical trial of non-drinkers, light drinkers, moderate drinkers, and heavy drinkers, the highest risk populations were folks who had between 10 and 30 grams a day, and then much higher in folks who had greater than 30 grams a day. And I know that we don't typically think of alcohol in grams as well, so I'm just including that one traditional drink, one 12-ounce glass of beer, one 5-ounce glass of wine, or one shot of liquor has 14 grams of alcohol. So if you're having one drink a day, that already puts you in the moderate drinker category. And if you're having 2 drinks a day, or a little bit more than 2, that almost puts you at the heavy drinker category. So, and in women, having 2 drinks a day does put you in the heavy drinker category. So a lot of times the recommendations are to limit your alcohol use to 1 or 2 drinks a day, but I think that is probably still too much if you're trying to eliminate your risk of colorectal cancer. Some of the numbers were also related to frequency of drinking. So for folks who had a couple drinks on the weekends, that seemed to be less dangerous than having drinks every day, with the number of days per week being correlated with an increased risk of colorectal cancer, as you see there. So 5 or more drinks a week, or 5 or more days a week where you're drinking had a 27% increased risk compared to just drinking alcohol in 1 or 2 days. So as I mentioned with the fiber, in general, getting nutrition from a variety of foods is better at preventing colorectal cancer than using supplements to meet needs. And fiber supplements by themselves don't seem to help as much as just changing your diet. So folks who did the insoluble and soluble fiber supplements that you can kind of mix in drinks and things like that, that does help a little bit, but does not seem to help nearly as much as for folks who adjust their diet and try to include more fiber containing foods. And decrease their non-fiber containing foods. And similarly, like I mentioned earlier with the vitamin D, I forgot that I put this line here, that supplementation is certainly helpful, but that vitamin D consumption via the foods and sunlight is better. There is a clinical trial that was kind of making waves in the news for a while, a couple of years ago, and they did this really large clinical trial for kind of low-cost preventative measures that adults who are 70 or older could do to reduce their risk of a lot of different diseases, fractures, frailty, failure to thrive, but they included malignancies in that. And the trial basically randomized adults who were kind of regular health adults who are over 70, and this was in Europe, to either having a 30 minutes, 3 times a week exercise program, mostly light exercise like walking, vitamin D3 daily of 2,000 units, or 1 gram of omega fatty 3 acids. And they randomized to either 1, 2, or all 3. And then they looked at all of these outcomes over the course of the next few years on people who participated in that. And they found that if someone did all 3 of them, exercise 30 minutes 3 times a week, vitamin D3 supplementation, and omega fatty 3 acids with a gram of that, they had a 61% reduction in all malignancies at the end of that 3-year report, and a 30% reduction in GI malignancies alone. So GI malignancies played a relatively large role in that. The numbers of overall malignancies developed in that trial were relatively small, so there needs to be additional studies done. But this is one of the first big trials that kind of really confirms that some of these preventative measures can prospectively reduce development of cancer. And I think that there's going to be a lot of more data coming out about this. And these are all relatively low impact, cheap things to do. So I recommend it for all my patients who are interested in reducing their risk, and not just folks who are over 70, because I think that the data can be extrapolated to younger people as well. Physical activity, easier said than done. I know that very well. I've got 2 young kids and have very little time to try and exercise, but trying to set aside at least 30 minutes 3 times weekly, it can be invaluable for so many different medical reasons, but colorectal cancer and just general cancer prevention is one of them. The cancers that seem to be most affected by sedentary lifestyle are colon and breast cancer. And that's probably because those are the 2 of the most common that we see. And so we can get more data on whether or not we're preventing them. But it's suggestive that decreased inflammation in your body can help decrease the risk of developing cancer in the long term. So obviously physical activity is good. We all know that. But this is just another reason to help motivate us to get those 30-minute exercise sessions in at minimum a few times a week. And then there was some clinical trials that suggested that doing more than that, exercising 30 minutes daily, had a stronger benefit and a reduced risk of cancer compared to 3 times a week. So do as much as you can tolerate without hurting yourself, I think is a good takeaway. So I mentioned before the definition of secondary prevention. So I kind of talked about things that we can do to reduce our risk of developing cancer. And then what are some things we can do to monitor ourselves and identify cancer early? Because we know that the earlier we find colorectal cancer, the higher chance of cure without having to do chemotherapy, and the higher chance of cure without a chance of recurrence. So the rule number 1 and maybe number 2 and maybe number 3 should all be stay up to date on your colon cancer screening, whether that's a FIT test or a Cologuard. But I personally think that colonoscopy is just such a valuable tool. They can go in and directly see, they can remove polyps before they become cancer. They can see things that scans might miss. We're getting better at the other techniques to detect colon cancer, but colonoscopy is still the gold standard. And if you're doing FIT test and it's positive, then you still have to get a colonoscopy anyway. So I strongly recommend colonoscopy if you're able to do it. And then I strongly recommend following with the United States Preventative Task Force Service about colon cancer screening with all of the other tests that they recommend, like the FIT test and the Cologuard and things like that. Another big step and another important step is understanding your family medical history, your personal medical history. The number of times we have new colon cancer patients come in who have had symptoms for years and didn't think that it was important enough to bring up to their primary care doctor is really high. I mean, people have GI upset all the time for a million reasons, but if it's persistent and it's causing blood in your stool or anything like that, you need to really be aware that that's not normal and that you should be getting medical care or finding a medical doctor to talk to you and get you sent over for a colonoscopy as soon as possible, or at least an evaluation. And then also having a family history of colon cancer, even if there's not a genetic condition, that's also really common where someone will come in and they'll have had some GI symptoms for 6 or 8 months. And my dad had cancer, his dad had cancer, but there's no genetic screening. They did screening and there's nothing genetic. Well, that's true, but even just having a family risk without genetics can increase our risk for developing colorectal cancer. So just being aware of all of that medical history, talking about it with your family, making sure you've got a good idea of what your symptoms are. Those are all important in trying to catch these things early. Cologuard, which is one of the companies that does the which I don't have any relation to them, but they do the colon cancer screening that you can send in. They did a study from it was 2006 to 2012, and all of the new diagnoses of colorectal cancer were in folks who were not up to date on their colon cancer screening. And that makes sense to me because folks who are up to date catch these cancers early, and the ones that catch them late, usually the cancer's later stage, which is a worse prognosis. I'm not going to spend too much time talking on this. Your primary care provider should be kind of talking to you about getting set up for colorectal cancer screening. I list all of the different ways to do it. I highlighted the colonoscopy in green. I don't do colonoscopies, but as soon as I'm able to, I'm going to get them every time I need them. They're just so valuable, and they've really helped reduce the mortality of colon cancer and allowed us to diagnose these early, which is just so important because the earlier you diagnose, the better. I'm going to stop harping on that, but that is something that I feel very passionate about. Yeah, and then they also recently lowered the age from 50 to 45, and that's just because of the increasing incidence in that 45 to 50 range. I think that we're going to get more and more data that suggests that some people who are higher risk might get testing sooner than that. And then if you have a family history of cancer and a primary relative, I think I'm going to talk about this a little bit more later, but getting a colonoscopy 10 years before they were diagnosed is something that you should bring up to your primary care doctor and get sent over to gastroenterology to get a colonoscopy done sooner than later is certainly something that we would recommend. Oh yeah, here we go. This is the slide that talks about it. So if you have a first degree relative, like any sibling or parent or child that had colorectal cancer, then you should get a colorectal cancer screening starting at age 40 or 10 years younger than them, as soon as you know about that. And then they kind of still recommend that if you have second and third degree relatives like cousins or aunts, then starting at 45 is reasonable. But I think that if you have multiple family members with colorectal cancer and you have any symptoms at all, I would have a low threshold to push your primary care doctor to kind of recommending a colonoscopy. Better safe than sorry. I just put this slide to kind of, again, talk about why I love colonoscopies so much. So you can kind of see on the left side of the slide, when you first start to develop a little polyp, which is like an overgrowth of the lining of the intestine. This is kind of how the common types of adenocarcinomas form in the colon. Is initially it starts as a little bump from an overgrowth of cells. Some cellular damage happened, and now those damaged cells are proliferating or growing super fast. And then it grows into a slightly bigger polyp and a slightly bigger polyp and a slightly bigger polyp that starts to have even more cell damage. And then eventually that will turn into cancer. And we think that this whole process takes a long time, which is why colonoscopy can be done every 10 years. But if you have evidence of multiple polyps at one point, then you'll need to decrease how frequently you're getting or increase how frequently you're getting colonoscopies based off of how many polyps and what kind of polyps they find. And this is another reason that just scans alone aren't helpful, is because these are little tiny guys in the middle of the colon, and the colon is on a scan is kind of wrapped up and folded, and it's really hard to tell the difference between a small little polyp and just normal folds of the intestine. So getting in there and visualizing it directly with a colonoscope is just it's the gold standard. And that way they can also grab a tissue sample right then and there and then tattoo the area with some ink to make it easier if you end up needing surgery. So for all those reasons, colonoscopy is great. So these are some other risk factors for colon cancer. Like I said, if you've had a history of it in the past, if you have a history of polyps, if you have inflammatory bowel disease, either ulcerative colitis or Crohn's, there's earlier recommendations for colonoscopy. And then if you have any history of cancer at all as a kid or a young adult, then getting more frequent colonoscopies is recommended as well. And then cystic fibrosis. If you have that, you need to be seen by someone who knows how to deal with cystic fibrosis and all the additional screening they need. Here are all my sources. I tried to include stuff that was really robust data so that we weren't just kind of speculating. And I just want to finish off by just saying that if you have any symptoms of GI upset, if you have red blood or black blood in your bowel movements, if you feel lightheaded, or if you have persistent iron deficiency and there's no other cause, or if you have change in your bowel movements, if you have any unexplained weight loss, or if you're sweating through your clothes at night, or if you're developing some lumps or bumps anywhere, all of those are things to see your doctor about as soon as possible. So don't delay. And then I think the sources slide moved up earlier in my presentation for some reason. I apologize about that. So I'm not going to talk too much about this, but there's a lot of additional studies being done. We're getting so personalized with genetic mutations in medicine that we're going to be able to really give people information on their risk of developing colon cancer and also their risk of developing colon cancer from certain risk factors. So we're going to find that some of these genetic predispositions have a higher risk of developing colon cancer with increased red meat intake and with increased alcohol intake. And all of that research is ongoing, and it's very exciting so that we can have more information to help us make decisions about how careful we should be with our diet. I just wanted to briefly talk about circulating tumor DNA. Right now, we're using that for kind of monitoring colon cancer in some cases. So you can check the blood with a blood draw for circulating SNPs of colon cancer DNA that can tell us whether or not there's still active colon cancer cells in the body. There's ongoing studies to try and get this as a screening tool as well, but that's, I think, a long way away. I recently wrote a blog post that kind of talked about how there's a lot of excitement around artificial intelligence, particularly in the medical field, to coordinate artificial intelligence and read lots of pathology slides and imaging studies to capture the extent of cancer and help determine whether or not there's some abnormal cells that used to maybe be considered borderline, that maybe with some computer assistance we can kind of be very objective about diagnosing these cancers and atypical cells early. And then, of course, there's a lot of ongoing efforts to try and extend how many colonoscopies we're able to do to folks who don't have access to as much healthcare. So I think all of those things are going to continue to improve. I think we're going to get some more data about who and how frequently we should be testing folks and how soon we should be testing folks to hopefully continue the trend of decreasing mortality and figure out this problem of earlier onset colorectal cancer. Oh yeah, so there's where the other source slide is jumped to. So I think that's it for me. I think this question slide is the last one. So I was going to open it up. I see there's some questions and answers at the bottom here. Let me pull this up real quick.
Thank you, Dr. Taylor. As you mentioned, we'll now transition into our Q&A session. If you haven't already, you may submit your questions using the Q&A chat feature at the bottom of your screen. And if it's okay with you, Dr. Taylor, I'm happy to kick us off with our first question.
Yes, go for it.
All right. It looks like you may have used the acronym GI. Would you be able to share what that stands for?
Oh, I'm so sorry. So GI stands for gastrointestinal. GI doctors are like gastroenterologists. So the cancers that we're talking about are the cancers of the GI tract from the esophagus, the stomach, the small intestine, the large intestine, and the rectum. That's kind of the gastrointestinal tract. My apologies for using medical jargon.
Perfect. No, thank you. Our next question is a little bit of a two-part. So for the first question, and I do apologize if I mispronounce anything in this question, but are Cologuard tests reliable for someone with a urostomy and ileal conduit?
Oh, I see. Yes, so for certain folks who might have a higher risk factors for doing the actual intervention, doing something like a Cologuard, that's a great time to use Cologuard. Cologuard is very accurate, and it captures these cancers early. If you do have a positive Cologuard, then I think that you'll have to discuss with your doctor about the next steps. As far as getting further imaging, there's things they can do where they can maybe decrease the risk of impacting the ileum, which is part of the small intestine, such as maybe doing a flexible sigmoidoscopy to capture the distal part, or maybe doing some intensive imaging with a CT colonography or something like that. But I think that's a really good time to use a Cologuard if you have some risks of complications with a regular colonoscopy. But speaking with a gastroenterologist about it is also very reasonable if you haven't done that yet. Just to see what strategies they would have. Was that it for that question, or was there more to it?
So there's a little bit of a part 2 to that question as well. Does having an ileal conduit increase the risk of colon or rectal cancer?
I don't know off the top of my head. I'm sorry. I would have to do a little bit of digging and find out if ileal conduit increases the risk. Maybe they could get some and look at the slide or contact our office later, and I can do some digging and find out. I don't know off the top of my head. I apologize.
No worries. Our next question is asking, do we know specifically what ingredients in the processed red meat that makes it such an increased risk?
Yeah, there's a lot of ongoing stuff to figure that out. I think there's a few culprit things they're finding, but one of the things that at least scientifically makes sense to me, even if I'm not sure if this has been like proven directly, but with the increase in iron in the heme, which is like the protein that we have in blood in red meat, those higher amounts of digested iron can increase free radicals. And so I think that's one thing. But I think there's also other thoughts about specific types of acid that exist in red meat that doesn't exist in white meat that also has some heme in it too. So I think that there's still ongoing stuff. I don't know if there's been one culprit that we could try to remove from red meat so that we could all enjoy it and not feel bad about it. Good question. I think there's more to be learned.
Thank you. All right, we have another one asking, how successful is removal of a tumor once one is discovered during a colonoscopy?
Yeah, very good question. So the way we go about with treating colon cancer is dependent on the size of the tumor and the depth of the tumor. The depth meaning how far into the wall of the colon it's gone. So whether it's gone through those layers of muscle or not. So frequently when a tumor is found and it's not just existing in a small little polyp, then you will go for surgery and they'll cut out that section of the intestine. And then when they are able to cut out that section of the intestine and look at it under the microscope, they can see how far that tumor has grown into the colon and if there's any lymph nodes nearby that are involved. And whether or not it's gone all the way through the wall or gone to a lymph node, or if it's just kind of right in that first layer, it can greatly change your chance at having that cancer come back. But usually, if it's an early stage thing, like a polyp that's found to be a cancer, or if it's a stage 1 cancer, the success rates are very, very high. The further the stage goes, if there's nodes positive or if it looks like it's spread to a different organ, then the success rate goes down a little bit, of course. Good question.
Wonderful, thank you. Our next question is asking, if you have frequent blood in the stool but recent colonoscopy shows no signs of cancer, should you ask for more frequent checks?
This is tricky. It sounds like let me think about how to answer this. So there's a lot of reasons to have blood in the stool that are not related to cancer. One is, for example, diverticulosis. If you have little outpouchings in your colon called diverticula, there's a thinning of that wall of the colon. And so sometimes those are more susceptible to having little bleeds when they get inflamed, and they're not really cancerous. I think that depending on how much bleeding you're having and what exactly was found could change whether or not you should be seen more frequently. If it was bleeding from like a polyp, then I think that they would recommend increased colonoscopy. But if it was just from diverticula or from internal hemorrhoids, then that's a benign cause of bleeding. That's an excellent question as well. But I would touch base with the person who did the colonoscopy and kind of see if they have any thoughts about doing it more frequently based off of what they found. But like I said, for those benign findings, that wouldn't change how frequently you're getting a colonoscopy.
Wonderful, thank you. Next question is asking if you could explain the difference between Cologuard and a colonoscopy screening.
Yeah, so Cologuard is a company where you give them a sample of stool, and they look through the sample of stool to see if there's any. They do some stains on the stool, and they do some tests on the stool to see if there's any evidence for a chance at cancerous cells in the lining of the colon. And that's just a test where you send stool into a company. They have a proprietary technology that they use to examine and analyze that sample, and they tell you whether or not there's a positive or negative test that suggests whether or not there's risk for cancer cells in the colon. And then you would get a colonoscopy, which is a procedure where you a procedure where you go and have a specialist doctor, usually a gastroenterologist or sometimes a surgeon, and they take a fiber optic camera and go into your colon and look at the entire wall of your colon. And they kind of go all the way up into your small intestine, looking at the walls of the colon to see if there's polyps, seeing if there's areas of ulceration that look like they could be cancerous. And if they see something like that, then they take a sample with some forceps. They grab a little bite of it, and then they can look at those cells under the microscope to see if they look like they're cancerous or not. So the colonoscopy is kind of a direct visualization, and the Cologuard is an analysis, basically, of the stool.
All right, thank you. Are store-bought pills a good way to get the recommended amounts of fiber, vitamin D3, omega-3 fatty acid, and supplements like those?
Yes. So it's better to supplement vitamin D and fiber, I think, in omega fatty 3s. I think that's better than not doing anything. But I think that the kind of studies that I had talked about certainly saw benefit in supplementation with like the synthetic vitamins that are marketed and sold. But there seems to be a slightly bigger benefit to incorporating those from actual foods. Vitamin D is really hard to get enough of. So I think vitamin D supplementation is something that I would recommend to anyone who's got low vitamin D levels. And then for fiber supplementation might just be required with how hard it is to get that much fiber in the diet. But trying to incorporate more fiber containing foods would be my preference. And then same with omega fatty 3s. That's a good example of a supplement you could take. And that was demonstrated in that DO health trial that Europe did, is they were given vitamin D3 supplements and omega fatty 3 acid supplements. They did not have like special diets that increased those. So the supplements were shown to be effective at reducing cancer risk. That's a long way of saying, yes, supplements are good. I think trying to increase food fiber is best, but if you have to take supplements to get your fiber needs, then I think that's a reasonable thing to do.
All right, thank you. I have a few dietary questions, so it's okay if you may not know the answer. The first one is asking, you did mention that black beans, lentils, and other types of beans are good for increased fiber. Someone's wondering if it matters if they come from a can of uncooked beans, or is there a better source of digesting those beans?
I think it depends on like the way it's packaged in the can. You'd have to talk to somebody who knows a little bit more about food packaging. I think in general it's better to have like the dry beans that you soak yourself, but I think that canned beans still have a lot of fiber, and I'm not sure the difference between the two. I would not let that stop you from. I would do canned beans over no beans for sure, and then I can do a little bit of research on whether or not soaking beans is so much more valuable than canned beans that it would be worth talking about. But I do canned beans a lot.
All right, thank you. Somewhat of another dietary question. We have someone who has been managing IBS-D. They've had a colon resection, chemo, and radiation for colorectal cancer. And everything seems to upset their stomach, and they're wondering if you have any tips or tricks to help managing that.
So a colon resection and chemo and radiation for nearly stage 4 colon cancer. So they gave you all the treatments, and ever since then you've had a hard time with eating foods and not getting diarrhea. Yeah, that's a really tough one, because if you've been through that much treatment, there's probably some permanent damage to the GI tract that would make it really hard to completely control diarrhea. And I guess I would have to kind of I would have to talk to you more in depth to kind of figure out what's been tried and what's not been tried. And I wouldn't want to give like broad advice that might not be helpful for you. But I think that there is a world where there's a new norm for you, where looser stools is just the way things go, depending on how much they had to resect and things like that. So I'm sorry to hear that you're dealing with that.
Thank you, Dr. Taylor. Our next question. Some people use all meat diets to lose weight. It sounds like this would raise their colorectal cancer risk. What are your thoughts on some of these popular diets?
Yeah, I mean, I've certainly read about some of the more restrictive diets, like the people who do the paleo diet, where it's like high meat, and they seem to have really good healthy outcomes. Um, and I don't think that any of these clinical trials were comparing like high red meat with high carbohydrate intake with just red meat alone or something like that. So I guess I can't say definitively, but I would guess that if the components of red meat that increase our risk for colorectal cancer are still being eaten, that they would have a mildly increased risk, but that would be speculation. So a diet is such a personal thing, and depending on what goals you're trying to get out of it, I can't say yay or nay on that at all, except for that I imagine that there probably still is an increased risk of colon cancer for folks who are eating only red meat or something like that, especially if they're not getting enough fiber. But studies need to happen about that, of course. Yeah.
Thank you. If cancer is discovered in a colonoscopy, what are the next steps and what are the usual treatment options?
So the way it typically goes is cancer is discovered on a colonoscopy, and a sample is taken, and that sample is given to a pathologist. And a few days later, the pathologist reads the sample and says whether or not it's cancer. And then typically that patient has some scans done and meets with a surgeon and a medical oncologist. And the surgeon talks about doing surgery to get rid of the cancer, as long as the scans show that the cancer is all contained in the intestines, or the intestines and the lymph nodes. And then after surgery, if there's no evidence of disease that spread beyond the colon and they do surgery, then the surgical specimen is what decides whether or not there's a benefit of chemotherapy or radiation or a combo of the two. So it typically goes colonoscopy, scans, surgery, and then further discussion depending on what level of cancer that is found on the surgical specimen.
All right, thank you. Our next question is asking, of all the lifestyle risk factors that you mentioned, which do you feel would be the most important to change? For example, quitting smoking, physical activity, obesity.
Yes, so just by the numbers, quitting smoking is definitely super beneficial. I think that increasing the fiber seems to also have the most benefits with the least amount of restriction on your life. And then, of course, cutting back on alcohol and red meats is a lot harder for some folks. So I think that doing those in moderation is more reasonable. So in my mind, it would be quitting smoking would be very, very important. Moderation for everything else, and then increasing fiber would be really important as well. But the most important thing would be keeping up with your colonoscopies, or at least your colorectal cancer screening, if that's Cologuard or colonoscopies. Keeping up with that would be super important in my mind.
All right, thank you. If someone gets a tumor in the bile duct area, is that considered colorectal cancer?
There is a cancer of the bile duct is called cholangiocarcinoma. It's another kind of medical jargon word, and it's a different entity than colorectal cancer, even though a lot of the treatments sometimes overlap. And a lot of times the same type of oncologists see both colorectal cancer and cholangiocarcinoma. So that's a different entity, and a little bit cholangiocarcinoma is a little bit rarer or a little less common than colorectal cancer. So I don't think there's been as much information about the risk factors for cholangiocarcinoma as there is for colorectal.
All right, thank you. This next question is a little specific, so if it's too specific to answer broadly, that's okay. I'm going to take a stab at reading it for you. We
Okay.
have someone who has a family of colorectal or has a family history of colorectal cancer. And they did have some polyps removed when they were around 50. However, they are now 73 years old, and they did not want to go through the prep process. So they opted to do Cologuard, but they're wondering if, given their history and that they had polyps removed, if they should have gotten a colonoscopy.
That's a good question. So at 75, from 75 to 85 or 76 to 85, the USPSTF questions whether or not it's worth it to continue doing colonoscopy screening. And they say it's a personal decision about whether or not you want to continue doing cancer screening at that age, depending on how healthy you are, if you have other health issues. Because if you're healthy enough to undergo surgery and potentially chemotherapy or potentially, surveillance treatments, and you'd be interested in that, continuing to do screening is very reasonable at that age. So you're still in the age where you would definitely qualify for screening. And depending on how healthy you are, I would continue doing it. The decision to switch from colonoscopy to the Cologuard because of the difficulty with prep, I understand it and I empathize because I understand that it's just very, even though I have not yet had to do it, I've heard a lot of how challenging it is to do the prep. I don't think it's unreasonable to do Cologuard and then just be aware that if it's positive, then proceeding with a colonoscopy would be the next step. So as long as you're willing to get a colonoscopy, if it's positive, then continuing with that was very reasonable. With your history, I think that the polyps they found when you were 50, if you've had other ones since then and they didn't find anything, then I would say that you shouldn't be so worried about it, and the Cologuard seems reasonable.
Thank you, Dr. Taylor. We did receive a question through email. Do you have any thoughts on the effectiveness of Galleri blood test cancer screenings and whether that can accurately find early stage cancers?
Sorry, Galleri blood test?
I might not be pronouncing it correctly, but it is spelled Galleri.
I am not familiar with that. I'm not sure if that's can you read the whole questioning? Maybe they're talking about circulating tumor DNA. Let me see if I
Yep,
can.
I can read it again. Any thoughts of the effectiveness of Galleri blood test cancer screenings and whether that can accurately find early stage cancers?
I'm just looking at this, trying to figure out if this company is the same thing as our Signatera. This sounds like it's another company that does circulating tumor DNA, and as far as using it to screen for cancer rather than using it to monitor if you have a known diagnosis of cancer, I think that the jury's still out on that. I would have to read up on their specific type of test and what studies they've done on it to see if they've tried to show that screening works. That was in the emerging data, and I just have not heard of that company before. But the other companies that do something similar, the screening component of it compared to just the monitoring component hasn't been as well studied. So I think there's more data to come out about that. But I think that's exciting too, and that could be the future as well. Although we do know that there are some cases where tumor DNA does not circulate in the blood very well, even when there is active tumor. So I think that there's some development of the technology that still needs to be done before we trust it entirely.
All right, thank you. Next question. Somebody has a first degree relative who ended up passing away from colorectal cancer at the age of 35. Given that they were a first degree relative, is that something they should consider when talking to their doctor about having a colonoscopy earlier?
Yes. You should 100% talk to your doctor about getting a colonoscopy as soon as possible. I mean, at 25 technically, but I would just get it done. If someone passes away in their 30s, I think that's really worrisome that there could be something going on.
All right. Well, thank you so much. That actually was our last question. So we can give everyone about 10 minutes back in their day. Thank you once again, Dr. Taylor, for your wonderful presentation and insightful Q&A. To all of our participants, thank you for joining us, and we hope you have a wonderful rest of your day.
Thank you for the opportunity.